This conference will now be recorded.
Happy New Year, everybody.
Yeah.
Happy New Year. It's the 1st of January. And so we wish everybody in the group and all our participants and everybody who watches on the recording the healthiest possible 2024, along with a lot of joy for everybody. This is Rick Davis. I'm moderating tonight. We have a relatively small group. There are many people watching football, no doubt, but some are in the group tonight, and we have a number of people who would like some time. So I think we'll fill up our allotted space, our allotted time. Big thank you to our sponsors, Bayer, Myovant Sciences, J&J, Myriad, Telix, and Blue Earth. I hope we'll add a couple more during the course of this year. I also hope the people that make enzalutamide will come back online. They've kind of abandoned us, which is not very nice. So we're not mentioning the makers of Xtandi anymore, or at least for a while. Sadly, they were one of the very first people to endorse us, so I don't know what's going on. I think they're upset with me because I've been taking the AUA to task about their lack of concern about mental health for people living with GU cancers, and especially prostate cancer. And we ain't giving up on that one, so I may, because of that, have lost them along the way, since they are the major sponsor of this fake group at the AUA called the Prostate Cancer Impact Alliance, which is no more than window dressing for the AUA, for them to say that they're doing something for patients when really they're doing sweet diddly. So Larry Fish, would you like any time tonight?
No, thank you, Rick.
Okay.
Larry, do you go down to Times Square every year? Larry, do you go down to Times Square every year on New Year's?
Oh yeah, I put on my Depends and stand there all night.
Yeah, when I was 12, 13, 14 years old, I used to take the subway into the city and do that every year on my own.
I think I did that at that time, but
I just like to take a very quick survey before we start, and because I suspect I already know the result of this survey, with the exception of Peter Kafka, who did stay up till midnight last night and made sure he told me. Is there anybody in this group, anyone else in this group, who did see the New Year in at midnight? Oh, Jeff Marchi and Bill Rao. Oh, and Jimmy. Okay. I'm surprised. I thought Peter, our wild, now we know who the wild guys are here. Okay.
Well, we watched the ball drop live, but we're on the West Coast, so I was in bed by 9:30.
There you go.
I watched it live too on TV.
Yeah, these West Coasters don't get full credit now.
Well, it's wild over here because fireworks are technically illegal, and one or two of the hotels put on a big show on a barge out in the water, but there's more fireworks than there are cops, and somehow people get them here, and the whole neighborhoods are just. I mean, it looks like the War of 1812, and it really does look pretty crazy here. And so it's worth waiting up till midnight, and we watch it from Susan's deck because you get a 180-degree panorama of different neighborhoods. It's pretty amazing.
I would
It's
have
the
thought
same
you
here.
guys had had enough of smoke and fire for 1 year already.
Oh, we're not into smoke and fire, but you see it from a distance. It's nice. And you hear it.
Peter, since you have the floor, why don't you start us off?
Okay, mine's a little more of a question. I'm glad Dr. Jack is on because he might be able to weigh in on this. Today is the first day in a month that I'm actually feeling okay. And there's a reason for it. So I'm not going to, I mean, I've told you all what I went through, colonoscopy and a month of heavy duty diarrhea and so forth. And then it looked like maybe it was parasites. So they put me on Flagyl or metronidazole, whatever it is, otherwise known as Flagyl, which is, I think, it's the first time I've been on it. It's a pretty heavy duty antibiotic. So I made it 9 1/3 days out of supposed to be 10. I just gave up yesterday at noon. I just said, I just can't take this anymore because I think that was driving my diarrhea at this point. And so I've been off it now for 24 hours and I feel much, much better. I don't know. This is the first time I'm eating a little bit of rice to see if I can hold down solid food and it doesn't run out of me like a faucet. It's probably going to take several days. I'll probably have to eat some cashew yogurt with probiotics and stuff, try to rebuild some stuff in there. But my question, particularly for Jack, giving you guys, is what happens if you don't take the full 10-day course of an antibiotic or the full 5-day course or something like that? If it's pulling you apart and really making your life miserable, I mean, can I assume that the stuff did its magic and did its trick, or have I messed up and have to go to jail for this?
First, it's not an antibiotic. It's an anti-parasitic drug. Flagyl, commonly used for trichomonas and vaginal infections, and it's also used very commonly for people who have ulcers, and they treat Helicobacter pylori with it, and it's so commonly taken. Diarrhea is a side effect. It does occur. You're not crazy. It's fairly common. And taking it for 9.5 days rather than 10 will not make a difference. It did its effect.
That's what I want to hear.
Any reason to be concerned? It's generally a relatively innocuous drug. I'm sorry you had bad diarrhea. Most people I've seen take it. I take it myself when I had the Helicobacter infection some years back, and I didn't understand why my stomach was burning, and then they put me on Flagyl and a couple of antibiotics, and it really did the trick nicely. So it's a sort of a miraculous drug in combination with the antibiotics. Years ago, we used to rip out people's stomachs with operations, Bill Roth 1, Bill Roth 2, and now they're just giving antibiotics and antiparasitics. So I think you're going to be fine, Peter, from my point of view. And
I'm hoping so, yeah. But I always wonder about that, when they tell you, well, the course is 5 days or 10 days and take it till the end. And sometimes.
And, I really thought about that colonoscopy you had, and I thought about, it's been reported in the literature, a lot of practitioners fail to sterilize their colonoscopy instruments and, pass on all kinds of crap, literally, to other patients. And it really has to be autoclaved and whatever they do with it very carefully. And I don't know what they do in Maui, but, sorry you had to go through that.
Yeah, I'm gonna meet with the surgeon on tomorrow. No, Wednesday. Have a follow up and see what he has to say.
One thing that has been raised in my mind from Peter's incident, and I think we could only get a good answer from somebody like a Dr. Antanourakis or a Dr. E, is that when you stimulate the T cells through an immunotherapy, how does that impact more common drugs like antibiotics or antiparasitics?
Don't know. I know when I was on Keytruda, I, I I felt a strong reaction. I was still taking when I first started. I was still taking darolutamide, and it started acting weird on me, and I decided I better stop. And that's when I
Hmm.
stopped darolutamide. So that was
Hmm.
a year and a half ago. But it was nobody told me that there was an interaction, but I could sure feel something different with the darolutamide.
I mean, I would just think that the way these immuno drugs work by stimulating the T cells, um, there's got to be some interaction with things like antibiotics, but I don't know. Maybe killing off the T. I don't know. I don't know.
Right.
It's well above my pay grade. Anyone else ever thought about that or?
I think the doctors are really guessing. I mean, I don't think they have
Yeah,
a clue what's going on.
yeah, yeah.
So my new oncologist, I meet her, next month or later on this month, I think, here, and she went to school at the American Medical University in Nevis. You ever heard
Right.
of that?
I
I
did.
think I
Yes.
think it's number 500 on the list of
Yeah.
medical schools in North America.
Yeah. It's sort of kind of like the guys in my day who used to go to Italy to go to med school or what have you.
Yeah. So
So,
I'm curious to see what she's like. We'll see.
um, anybody have any other questions or comments for Peter before we depart? His
It's John Kish. I have one or two ideas. I'm not a doctor, but don't get mad. Hello?
yeah,
Hello?
you go ahead, John. Go ahead, John.
Cipro might work for him because that's used for anthrax. I don't know, but I know I was just on Cipro because I'm diabetic and I'm allergic to penicillin, but it interacted like with 5 of my medicines.
Mm-hmm.
But I know for diarrhea when I had radiation, which I know you think he brought up last week, peanut butter and bananas and rice worked really good for diarrhea, but he might have more serious diarrhea than I did from the radiation, so I don't know. Yeah, so that's just as a lay person, and I know oil of oregano is used for parasites, but that's just from a vitamin book, so I don't want to make him sick, I'm not a doctor. Yeah.
No, no.
So
Well, if he can eat bananas, he's got plenty of them in the back garden. So, so, so bananas are a good thing for Peter Kafka if he can keep them down. He's got plenty. When do they ripen, Peter? When do your bananas ripen?
All year long, depending on the weather. If you got enough wet weather, they come in. They ripen on their own. So there's
Oh,
they don't all come in at once. But oddly enough, when I looked up this flagell stuff, it doesn't go with bananas. Bananas is one food you stay away from when you're on this flagell stuff.
okay. Do your bananas taste like the bananas we get in the store, or do they taste completely
No, no,
different?
no. They're small and they're sweet. No, I can't stand store-bought bananas.
Okay. So the moral of the story is, folks, grow your own bananas.
Yeah.
All right, we're moving along, and Dr. Joel was here very early in the day today as well. So go ahead, Dr. Joel. General Joel, sorry.
Okay. Okay. Here I am. All
Yes,
right.
sir.
I just finished 5 SBRT treatments to my L4, L5, T6, and T9. Took place over November and December. I take a PSA tomorrow. I don't expect my PSA to have changed any. It was already at less than 0.04 for the past 6 months. The next time I see my radiation oncologist should be in April, unless my Dr. E tells me to do otherwise. I do see Dr. E again on 21 March. I also have a PSMA PET scan, gallium-68 Illucix scan scheduled with her, and a whole body MRI scheduled with her also. Basically the same scans that I took last August that showed I had no prostate cancer. I'd like to thank the couple of guys in here over the last 2 months that recommended Gemtesa. I asked my urologist for Gemtesa about a month and a half ago, and I went from 10 times a night, getting up 10 times a night to urinate, to about 5 initially, and now I'm down to sometimes I get away with three or 4. So it is working. The longer you take it, I guess, the better it works. It relaxes the bladder, so your bladder doesn't want to empty so frequently. So that's working for me anyway, as it worked for the other 2 guys who recommended it in the room. Also, Dr. E had put me on Mounjaro for hopefully losing 50 pounds. I did lose 25 pounds since 15 September. However, I got allergic to Mounjaro and I started getting red patches all over my legs. And in order to cure that, they had to give me a 10-day tapering dose of prednisone, which I have now finished a couple days ago. And so according to my dermatologist, those red spots will go away by March. And I'm headed for South Beach, Miami Beach, from 4 to 9 January in a few days. So I'm going to see some sun finally. Does anybody else who've been on Mounjaro who've been allergic to it like I have?
Anyone else
Anybody else been on
taken
Wegovy?
any of these? Has anybody else taken any of these weight lessening drugs, Mounjaro or Ozempic or Limpa or whatever it's called?
It's John Kish. I take Ozempic, but it's for diabetes, not weight loss. But I never had an allergic reaction, but it did cause my pee to be darker yellow, and pain in my neck and shoulder blades and constipation. But as I got used to the Ozempic, the side effects went away. But I know it's similar to Mounjaro, but it might be a little bit different. But he might tolerate Ozempic better. But I take it for diabetes, not weight loss. Yeah.
So, I mean,
Okay, very good.
that is
maybe Dr.
Yeah, that's what I was going to say, Joel. I mean, maybe it works in a different way, and we don't have Len here today, who kind of knows how these is good on how the drugs work. But maybe the Ozempic would work better for you, so you can get rid of the other 25 pounds. But then when you do that, we won't even see you. You'll
Right.
disappear into those palm trees behind you. You know?
I won't have that problem. Yeah.
Go
I don't think
ahead,
I'll
Jim
have that
Marshall.
problem. Nice problem to have. But I must say that, yeah. I'll get back to you, Jim. I must say that my blood pressure went down from the 150s down to 110 over 68. So that it did wonders to my blood pressure. They even, my heart doctor reduced my 3 drugs on me. The Crestor, he reduced amlodipine, which is Norvasc, and he reduced the valsartan from 320 to 160. So I'm taking fewer milligrams of drugs as a result. And my heart doctor was happy with the way my heart looked. So the Mounjaro does do a good job at not only the weight control, but it does help you with your overall health. Go ahead,
Well,
Jim.
I mean, of course, one question is, Jim, I'll get right back to you, but one question I would have to ask is whether the loss of weight is doing that as much rather than the Mounjaro, and however it works. I honestly don't know. Jack, do you know how these drugs work, and whether would just be from the loss of weight, or would it be from a chemical reaction from the
Well,
drug?
it has an impact on the appetite center, the leptin, and it just curbs your appetite phenomenally to the point where you just don't want to eat as much. That's what I read, and how it. I think it's the weight loss that causes the body to become healthy in general, and therefore you're going to have, all kinds of other beneficial effects from the weight loss. The medication just works on the appetite center. Did you find your appetite markedly diminished, Joel? Hello? Joel? Was your appetite diminished?
Yes. Oh yeah, that was wonderful. It was wonderful. It taught me what portions I should be eating, and so I'm trying to continue that now. But unfortunately, after 15 days of not being on Mounjaro, my appetite is voracious now. So I have to really try to limit myself as to what I eat.
The problem with those drugs, once you're on them, you have to stay on them the rest of your life. Otherwise, it comes right back. That's one of the problems.
Okay, we're going to go to Captain Jim and then to Jeff Marchi. Go ahead, Captain Jim.
Joel, could you put that drug that you happen to mention that happened to cut your 10 times down to 5 within the chat, please?
Which drug do you want me to put in? Mounjaro?
No, and we're the first one that you spoke about that happened to relax some of the bladder.
Oh, Gemtesa.
Okay, Tessa?
Gemtesa.
Oh, okay.
Would you
Jim,
put
is
that
that
in the chat?
GIM or GYM or what?
Yeah, Joel will figure out the spelling and he'll put it in the chat.
Okay, there it is. I put it in the chat already.
There it is, Gemtesa. There's a number of those drugs, Gemtesa, Mirabegron. I think Gemtesa is probably. Oh look! Check Julian, who's using Gemtesa. So, Mirabegron is another one, but Gemtesa is more recent. Julian, you want to say anything about Gemtesa?
Well, it was not for me. It was for my wife for urinary incontinence, and it
Right.
worked really well on her. But I didn't know
Yep.
you could lose weight on it.
No, you can't. We're getting our wires crossed. It was the Mounjaro that you lose weight on.
Ah, okay. But yeah, it worked for her.
Okay. All right. Jeff Marchi.
Yeah, I was just going to mention that Wegovy is the semaglutide. That's the same as what they have in Ozempic. So and that's the weight loss drug, Wegovy, for Ozempic. I don't know if you've considered trying that in order to get back on a weight loss drug, but you might consider Wegovy.
It's a good idea because sometimes.
Yeah, no. As a matter of fact.
Go ahead, Dr. Jack, and then back to Joel.
It's a good idea because sometimes they're not all equally allergenic. If you're highly sensitive to one, you may not be sensitive to the other because of the various ingredients they mix it with, which often causes some of the allergic reactions, not necessarily the drug itself, but the ingredients that they mix it with. So if you change for a similar kind like Ozempic or rather than Mounjaro, you may find yourself not getting a rash or an allergic reaction. So it's worth a try, Joel.
Very
Go
good.
ahead,
Yeah,
Joel.
Dr. E was going to put me on Wegovy. Yeah, Dr. E was going to put me on Wegovy initially, and then when she heard about Mounjaro, she decided that was a better drug for me, and she did that. The Mounjaro mimics two hormones in your body that one limits appetite and the other one makes you feel full all the time. And so the Wegovy only does one of those things, but it is a totally different drug. One's semaglutide, the other one's the Zaparide or something like that. So two different drugs. We'll see what she says, and maybe I can get back on something that'll help me lose the next 25 pounds.
Have you changed your exercise regime at all, or are you managing the same exercise but more easily, or what effect has this had on your exercise, Joel?
So I've actually done the same things. I have not changed my exercise routine. The exercise is the same. So all this was diet. This was strictly diet.
Okay. Okay. Well, good discussion. We covered a few drugs there. I think 5. Gemtesa, no, 4. Gemtesa, Mounjaro, Wegovy, and Ozempic. And just for clarification, the Gemtesa is for bladder control. The other 3 are for weight control. Okay, we'll move on. And welcome back, Bill Raup, from last week. Where's your lovely wife? Is she over your shoulder, or are we going to see her tonight or not? Yes,
There
there
she
she
is,
is.
my better half, the better
Hello.
looking half.
Okay, what's on your mind, Bill?
So I have appointments to see my, well, not my radiation oncologist, but the nurse on Friday. And then I also have an appointment on Friday to see my GU doctor and get lab work done. And then I'm also scheduled for my next shot of 3-month Eligard on Friday. So all those things are lined up to happen this Friday. Prior to the appointment, they asked me to get a PSA, and I went to LabCorp to get that, and it came back at a 0.1. So it's less than 0.1. Excuse me, I was just corrected. So anyway, so that's good, but they didn't do any of the other blood work, so that'll happen on Friday when they do a full blood workup on me. So I think I mentioned last time that I was concerned about continuing the Eligard past the 12 months, which comes up and this Friday actually. And the discussion last week was basically I should stay on it for at least 18 to 24 months. I understand the rationale. My discussion with the doctors on Friday are going to be, okay, I understand that. That's the general rule of thumb. But in my case, my specific case, is there any way we can determine how successful my 44 proton radiation treatments were in eradicating the cancer? No one's been able to tell me that, and I would like to get that answer. So I'm going to be asking them to see what they can do in terms of helping me understand. And am I still at risk? Are there still active cancer cells there? I know they're being controlled as long as I'm on ADT, but understand as long as I'm on ADT, my PSA should remain near 0, no matter what. So I'm a little concerned. I'd like to know if there's any possibility that the cancer is spread, even though the PSMA PET showed no metastasis to anything outside the prostate. And that was prior to the start of the proton treatments. But that's been well over a year now. So anyway, so that's kind of where I'm going with Friday's meetings with the doctors, just trying to understand if there's anything. I know one of you all mentioned that she had a PSMA PET scan twice this year, or last year, 2023. And I didn't know if there's a rule of thumb from Medicare or some other body that says you can't do that. Am I going to be arguing against the system and saying I'd like to get another PSMA PET scan? So that's, I guess, question number 1. I have a couple more questions, but that's kind of the leading question right now.
Let's focus on that one. I see that the general wants to say something on that one, but let me just tell you that usually the PSMA are as needed, as required. So you can get them at relatively short intervals, less than a year. In your particular case, it's probably a really good reason to see. I mean, some people will say to you, or maybe some people in this group will say to you, oh, well, you're not going to see anything because your PSA is at 0.1. But that's not the case for somebody who has known lesions. In other words, if we're trying to find out where your lesions are because you had a radical prostatectomy and your disease has recurred, we might not see anything at that lower level. But if we know you had a lesion and we want to see how those lesions have responded, then even if the level's low, we should still be able to see it, because if the cancer's there and it's metastatic, it's going to produce PSMA. So it's slightly different. So if somebody says to you, well, your PSA is too low, you say, yeah, but I want to see what happened to those old lesions. They're going to if they're still there, they're going to show up. And now, one would think if the PSA is low, that there isn't much going on, because the hormone therapy suppresses the cancer cells. But if the cancer cells are very active, they're still going to produce PSMA, and that's what happens when you become hormone resistant, because it doesn't work anymore. So our expectation would be that we're not going to see very much, but I think it's, from my standpoint, it would be a reasonable request to do a PSMA, and I don't see a reason why not. Let's go. Two people had their hand up. First, Joe Blanchette.
Yes, my information is that Medicare will only pay for one every 6 months. In my case, I had to take two because Dr. E wanted to make sure that my PSMA PET was concordant with the FDG PET. So I had to get my FDG at the Veterans Administration and not through the Medicare system. I'm going to go through the same process in March, because she still wants two more scans from me, and the Medicare will only pay for one. So it's once every 6 months is the rule of thumb that I know of.
Yeah, and you don't have this issue of the costs at this point. That's an issue that comes up with more advanced treatment. Peter, you had your hand up too.
I was just I mean, you kind of took the other tack, but I was just going to say I really doubt the doctor is going to agree to do one with a PSA in the undetectable range like that. I'd be very surprised if they'd write an order for it. But what do I know?
Yeah, but Peter, you have to distinguish the use of that PSMA.
Well, in this case, it might work, but you got to get a doctor. The doctor has got to be willing to do that.
Yeah, but they're two very different purposes. One is to check where the cancer is when you have recurrence, so we can treat it. The other is to see whether the treatment has had an impact and taken it away. And those are two different reasons. Now, if we're looking to see where the cancer is, yes, that's where we say 0.1, but a lot of people confuse that with the second issue. The second issue, I mean, if you have a man who has known lesions all over his body, but he has very low PSMA, even on hormone therapy, we can still take a PSMA and see if those lesions show up.
So that's what's going on. That you've got lesions all over your body.
No, he doesn't have lesions all over his body, but But Bill had a lesion that protruded into his bladder, and he wants to know if the treatment has gotten rid of that lesion that was protruding into his bladder.
Well, PSMA, from my understanding, is not great at at looking at the gland itself. So it's great looking at distant things like in your neck or your places, other places, lymph nodes and so forth. But I don't know whether it would show up. Maybe an MRI might show up something better.
Yeah, I
I'm
mean,
not sure.
it could be that an MRI test might be better to see if that lesion has gone, and that's certainly worth discussing. But again, if there is a prostate lesion somewhere that it shouldn't be, then the PSMA is going to show it. The PSMA is not great at showing the gland because all the cells express PSMA.
Right.
But that's why, I mean, and the other problem, Bill, in using a PSMA to determine how it's impacted this protruding lesion, and this may be an even bigger problem, is the PSMA is not very precise on where on positioning in the body, which is why they do the CT scan at the same time to overlay it so they get a sense. So in a sense, Peter's right. We're not going to really see exactly where, if something showed up where it was, the MRI is going to be better. I think that in your case, some type of scanning is probably appropriate, and you'll have to discuss it with your docs. One question I have for you is whether you've thought about getting a second opinion from Dr. Palla.
So I did reach out to Dr. Paller over the holiday, well, in between. It was late last week, and actually I got the phone number. It sounded like directly to her, and left a message. I haven't heard back yet, so I assume that sometime maybe this week I might hear back.
Okay.
My wife's getting treatment for an eye problem at Wilmer at Hopkins already, so maybe I can lump that together at some point. But yeah,
Yep.
I mean, it'd be great.
I mean, just for clarification, she's at Hopkins, but she's at Hopkins Sibley. She's not in Baltimore. She's at Sibley.
Oh, that's in DC?
Yes.
Okay, all right, that's fine. I'm still relatively close to either one, so it's no big deal.
Okay. Yeah. She's at Sibley.
Okay.
So all right.
So one thing we've never talked about that I know of, which is maybe a pretty strange thing, but in the situation you're talking about, I mean, what about having another biopsy? And an MRI guided biopsy and see if they can target cores that were just before and see if there's still activity in there. I mean, I don't know what the prostate's like after proton radiation, but I mean, would that be something? I've never heard of it being done before. I've never heard of anybody, kind of looking at it that way. But if there's real concern whether the radiation worked, maybe a biopsy would indicate that. I don't know.
Well, the RO post-treatment said that my prostate no longer existed. They killed the entire prostate. That was his only response. When I asked more questions, he said it's gone. We killed it. So does that mean they destroyed the entire prostate? It doesn't exist anymore, or is it just
No
an organ there somewhere? I don't know.
No, it means they think they did, because we've had gents who have had radiation across their entire prostate, and then the disease has recurred back in the prostate.
Oh, okay.
So in theory, yes, that's what they should have done. In practice, do we know? No. I mean, if you asked him, did he get your lesion? He'll say, yeah, it's blasted to high heaven. It's gone. But you say, well, prove it to me.
Yeah.
And so you've got to take into account the ego of the docs who are treating you.
Yeah.
Does your prostate function anymore? Are you able to ejaculate? Does it function?
No.
Okay.
No, there's no ejaculation anymore.
Right. So it's probably, I mean, he's probably right. It's not functional anyway.
Yeah, but again, Peter, not functional doesn't mean there aren't healthy cells surviving. You can still have healthy cells surviving in there. the muscle may have all been destroyed and what have you. It doesn't mean that there aren't. I mean, we know that because very often if you have radiation, your PSA still continues at a low level, very low level. So, guys who have had radiation might have a PSA, instead of it having been 10 before, it might be 1 or 2, but not 0, because they've still got some healthy tissue, but not enough to be a concern.
Right. Well, I've never heard of anybody getting another biopsy after radiation primary treatment, but I guess it's a question you could ask. I don't know.
I know that I had the fusion biopsy, so they did the MRI. They found where the lesion was, and then they were able to go in and pull those samples out that they wanted to, specifically where they knew the lesion was. So I guess maybe you're saying that I'd have to have an MRI and then determine if there's something to go sample.
Maybe,
Well,
I don't
I
know.
think that gets back to what we said before. I mean, some sort of scan is right, and it's reasonable for you to ask it. For it, what scan that is, we're not sure. It could be a PSMA, it could be an MRI. All of these concerns. Peter has valid concerns. I have valid concerns. We all have valid concerns. But for the sake of your anxiety and also for your own knowledge, now the fact that your PSA is now less than 0.1 is great. That's where it should be on this treatment. How long has it been? You've been on it for a year. How long has it been at less than 0.1?
Since June.
So, that's another reason really to maybe to proceed, because it's only half the time. The aggression of the disease is sometimes identified by how quickly you go down to less than 0.1 from the time you started, and you didn't get down to that level for 6 months, and that can be a concern. I mean, a lot of us, when we first went on, if we had a prostate and we were getting treatment, we dropped down within 6 to 8 weeks. So that to me would be a concern if I were in your shoes.
Yeah, the only comment I'll make is that they would not do another PSA until my radiation had been completed. So the 44 treatments, that time there was no readings of PSA. So I don't know from where it started at 12 down to 0.1 or less. There was no PSA samples taken. So anyway,
okay,
that's it.
All right. Did you get what you needed from us today?
Yeah, that's my main concern prior to the appointment on Friday. So I do appreciate it. That helps a lot.
Okay. You had
that's a quite legitimate question that all of us ask all the time. Is the treatment working? Whether it's chemotherapy, whether whatever we happen to be doing. I just finished immunotherapy. Is it working? How do I know? And the only thing we're looking at is the PSA often, and but we really don't know what's going on in this body of ours.
Yeah.
It's a mysterious thing, and if things are outside the capsule and working their way in other tissue, I mean, we don't really know.
All right. Well, see what I can find out.
Okay. All right. I know you said you had a couple of other questions. If we have time at the end, we'll come back to you.
Yeah, I got to sign off earlier because I'm at a friend's house. We're in Delaware on, staying with some friends. So I've got to sign off a little early, but I can. These other things can wait.
Okay.
Thank you very much.
Pleasure. Les, what's on your mind?
Well, on Thursday, I had a 2-hour chat with Dr. Luke Nordquist in evaluating this actinium 225 clinical trial. But in our conversation, he brought up this scan, the copper CU67 PSMA scan. I had never heard of that before. Are you familiar with that scan?
Well, I'm not familiar with it as a scan. I'm familiar with it as a with copper and its relationship to prostate cancer, to prostate cells, and I am aware that they are using copper in some of the radioactive copper in some of these treatments. So, but that's about it. Copper has an affinity to prostate cells, and many years ago, Don Moresi, God rest his soul, was getting treated at Duke by Dan George, who's a very, very good GU med onc, and Dan was promoting a trial called Give One for Dad, which combined antabuse with copper, because antabuse destroys cancer cells, and if we could link it with the copper would drag it to the prostate. And it was relatively successful. The problem with that treatment is neither the copper nor the antabuse have any patents that aren't patentable. So it's easy anybody could replicate it. And, he needed money because it was, I guess the NIH wasn't, or NCI wouldn't fund it. And they had some limited success, but it never took off. Jimmy, what's the generic name for antabuse, the drug?
You're asking me?
Yeah.
Why do you think I would know that?
Because from the time you spent in the 12-step stuff, antabuse is a.
We don't touch that stuff. We don't believe in it, and I don't believe in it personally, or do we believe in it? The program it's trying to save you from yourself. However, sounds like Jack.
And it's not it isn't methadone.
Disulfiram.
Disulfiram. Thank you. Disulfiram. That's it. Disulfiram. Thank you, Jack.
It's used for problem drinkers that need to stop drinking. It makes you sick, Dave. Isn't that the
That's
one
right.
that makes you sick?
Yes.
Exactly.
Yeah, exactly, Jeff. That's exactly what it is. Anyway, go ahead, Les. What is well, first of all, let me ask you, did you meet with Dr. Sartor?
Yes, about a month ago.
Right.
And he's the one that recommended Dr. Nordquist and this actinium 225. So that's why we went out there and listened to his 2-hour spiel.
Okay.
So he had Dr. Sartor had suggested that, or the other alternative was the cabazitaxel plus carboplatin.
The docetaxel plus carboplatin or cabazitaxel?
Cabazitaxel.
Okay. So, what is it? How does the copper come into play here?
Well, he was mentioning that as something connected with the evaluation, and I had never heard of that CU67 before. I was just wondering if you had.
Well, it's just another radioactive compound like actinium or lutetium, and I have heard about some trials going on with it, but not very much. But I've heard of it. I think in the context of therapeutic and not diagnostic. Was he talking about it therapeutic or diagnostic?
Well, I thought it was diagnostic, but I can't say for sure. He was covering so much so fast that Anyway, that was about it. I was just curious if that is something that's up and coming, or if it's
But what
something
about you?
past.
But what about you, Les? I mean, what about this actinium and what do you think? What might you do next? I mean, as I recall, the Pluvicto didn't make much headway, right?
Right. Yeah. Anyway, as far as from here, I can't find out much of the probability of either working the actinium 225 or using the cabazitaxel plus carboplatin. You know, how much each one of them could potentially do. But if, like, each one of them, there's a 5% chance of any kind of success, the cabazitaxel, so forth, I can do locally with a 22-minute drive, and the actinium I can do with a 7.5-hour drive. So if other conditions are the same, I think I'll take the cabazitaxel.
When was the last time that they took a physical sample from you?
Oh, that's been years. I mean, a biopsy?
Either a bone biopsy or a soft tissue biopsy?
Yeah, that's been probably a few years.
Well, I think what I would do first of all before you decide is I'd ask for a I'd ask them to take a biopsy. I mean, you have several lesions around your body, right?
Yeah.
Do you have do you have lesions in your hip? Do you have lesions
There's
otherwhere?
They're primarily bone. There are several places around, but they're hard tissue, bone lesions.
But other than the spine and the ribs?
Yeah, I think there was some in the hips. I don't remember. There were several places over the body.
So here, my strategy would be this before making the decision. The first thing I would do is get a bone biopsy and have that biopsy examined by not just a pathologist at Mayo, but by either Dr. Zhao or Dr. Epstein's lab. And let's see what this cancer looks like. If the cancer looks like it's morphing and changing into a different type of cancer, then the cabazitaxel and the carboplatin are the way to go for two reasons. The first is that that's the best treatment for the morphed cancer, and the second is that if the cancer's morphing, it's not going to express so much PSMA. So any PSMA based treatment isn't going to get to it. So rather than trying to make a decision on the basis of how far you are from the treatment, I would ask my doctor, I want a bone biopsy. I want to see, plus we can also send that off to Foundation and we can get the most up to date to see whether there are any mutations that have emerged that might make you eligible for another treatment.
Okay. I don't
Les,
fully understand that, but I hear you.
Les,
I'm sorry. Hold on a minute, Peter. I'm sorry. What did you say, Les? I missed what you said.
Well, I didn't fully understand, the reasoning, but I hear what you're saying. are you implying that the using this actinium would not impact the cancer if that was the case? You know, as far as the
If it was morphing,
yeah,
yes, I am.
okay.
If it was morphing, as this cancer morphs and turns more like small cell disease, small cell neuroendocrine disease, it doesn't produce PSMA.
Well, that was what they were implying at Mayo Clinic. What Dr. Sartor, I thought, was implying that it's been morphing. That, you know, according to this, what's that now? That stuff that 360 test for what was that?
Garden
Yeah,
360.
yeah, right. That it and everything else seemed like he felt that it was morphing. So I'm not sure what he was basing that on, other than just the other tests that have been run.
When did they do the Garden 360?
The last one was, I think, is in November.
Okay, and who suggested Garden 360?
Dr. Kwan.
Right. Most of the GU medical oncologists don't like Garden 360. They feel that the better test is either Tempus, Foundation Medicine, the Myriad test. They don't like the Garden test, number one. Number two, ideally, if we had soft tissue, that would be a very good candidate for one of these tests. Now, the other issue, which is a difficult one, is that when this cancer morphs, it doesn't morph consistently across all the body. So it doesn't mean that if you have one lesion that's morphed, all the rest of them have. Right. So what I would be doing, I would go back to Dr. Sartor and say, Dr. Sartor, is there a lesion that we knew was present before I started the PSMA and it's still present today? Is there a lesion that fits that bill? And if there is, is it in a place where we can biopsy it? Because that's the type of lesion that would indicate if you have a morphed lesion. It didn't respond to the Pluvicto. And as I said before you went on the AC225 trip, if you don't respond to Pluvicto, you're not going to respond to AC225 because it's the PSMA. It's not the actinium or the lutetium. It's how it gets to the lesion. And if you're not pulling it to the lesion, then you've got an issue.
Okay, but bottom line, would there be any reason to proceed with the actinium-225? To me, you are pointing also to going with the cabazitaxel.
If your lesions came back and they appeared to be regular adenocarcinoma, and if you were expressing PSMA in all those lesions, yes, then maybe the actinium is better than the lutetium. But if you're not expressing, if some of those lesions, this is why we do the concordance, because we see where the lesions are, we see where the PSMA scan says you have lesions, and if a lot of them don't express, there's no point in doing the PSMA therapeutic treatment. If, on the other hand, they are all expressing, then maybe there is reason to do actinium. But the fact is that, you know, I wouldn't want, especially with these treatments that are toxic, I don't think we should be throwing spaghetti at the wall. We need the best information we can have to determine which treatment is going to be best for you. And I'm not a doc, but if it were me and I was in your situation, I would say, well, let's find one of these lesions that didn't work. Let's see what those cells look like. We don't have to guess. Let's see what they look like. If we can get a sample, let's see if they look like small cell. And if they do, by all means, let's get that carboplatin as quickly as we can, because you don't have a long window. That's what Dr. Munster told us.
Okay, I'll see what I can find out. Thank you.
Peter, you've been wanting to get in for a while.
Now, a couple of years ago, when you had the surgical issue in your testes, did they send that tissue off for genomic testing at that time?
They didn't send it off. They just did the biopsy in-house at the Mayo Clinic.
I mean, that was what, within 2 years or 2 years ago?
That would have been last summer.
You know, you could ask Mayo to send that off to Foundation Medicine or something. They probably still have that tissue sample.
Yep. Okay. Did they see anything untoward in that tissue sample? Did you discuss that with Dr. Sartor, whether any of that tissue looked like it had morphed? Did he look at it?
I hadn't discussed that with Dr. Sartor, no.
Okay, well, that's a really good thing to discuss with Dr. Sartor and ask him, could he take a look at that tissue that they took out? Does it look like it was morphing at that point in time? He has a great eye. He's not a pathologist, but he knows what to look for.
Okay, I'll contact him and find out. Thank you.
Okay. Anybody else before we move on? Okay. Well, the one thing I would say is that time is of the essence, because if Dr. Sartor thinks that you are morphing, that's probably a great it's a very valid opinion, and if we can establish that you're morphing, then the sooner you start on this treatment of a platin plus cabazitaxel, the better you will be. Peter, didn't you do that combination, or was yours docetaxel and carboplatin?
Docetaxel and carboplatin.
Okay.
Well, that was one of my concerns about, because if I would go through any more of these tests, that's going to delay everything. And that was one of the reasons why, as far as going with the cabazitaxel, that could be started within a couple of weeks. I could do that almost right away. In fact, I've got an appointment tomorrow to get it set up.
Okay. So getting Dr. Sartor to look at your tissue shouldn't take very long.
Okay.
Because the tissue's in Rochester, he's in Rochester if he's not traveling, and that shouldn't take too long. Getting a bone biopsy and sending that off to FMI, yes, that could take a month. By the time they do the bone biopsy and you get the results back, that could take a month. So you have a good point. The other issue to discuss with Dr. Sartor is whether he thinks it's worth doing a analysis, an FMI analysis on Foundation Medicine, FMI. Whether it's worth doing a Tempus or Foundation, or doing a sequencing of the actual tissue from the testicle.
Okay.
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 Thanks.
Got something to work on there. Thank you.
Okay. Where's my list? Les morphing. Hold on, guys, because I'm trying to do about 5 things at once here. Let's go to Thomas Matika. Thomas, what's on your mind?
Okay, got my mic turned on now. Well, I just wanted to just inform the group that I've got my appointment set up for Wednesday with Dr. Alexandra Sokolova at OHSU, and I'm pretty sure she's a GU, genitourinary oncologist. There's nothing on that website that says that about any of those doctors that are in that group with Dr. Thomas Beer. But it does say that she has there was an article about her in U.S. News, and they put her down as a genitourinary oncologist. I don't know. That's just something there.
So
So
let me just respond to that. She is a GU medical oncologist. All those doctors who are pictured with from that Dr. Beer group are genitourinary medical oncologists. That link that I sent you are the genitourinary medical oncologists at OHSU. So you're safe, and she is definitely a GU med onc.
Okay, wonderful. I'm glad to hear that, And so it says here, though, that just because I'm ignorant about these things, it says that Dr. Sokolova specializes in caring for men with prostate cancer. Her special interests are in prostate cancer genetics. Now, does that have any relevancy to her overall diagnosis of my condition? Is she going to just see it through a genetic sort of lens, or am I reading too much into this bio?
No, you're reading too much into the bio.
Okay, good. I'm glad about that too. All right. Yeah. And I've read a lot too. I've looked at the guidelines. You were always talking about guidelines when I first came to the group, and I didn't know what that was. But in the last week, I've read the NCCN guidelines and the AUA guidelines. I've gone through those. So that was quite an education and good for prepping for my visit to her. And well, anyway, I'm looking forward to that. If there's any comments from the group about it, or anything I should ask her, that would be appreciated.
Write your questions down. Have your questions written or typed out, and a copy that you can give to her. So and think of everything you want to ask, so that maybe limit it to 10 things. But you want to make sure you don't walk out of there thinking, I should have brought this up, or I should have brought that up.
Right. Okay. One other. Go ahead.
Hold on a minute. Hold on, Thomas.
Yeah.
I want to make sure you heard what Peter just said. Okay. This isn't for you to write them down and to go in so you've got them in front of you. It's for you to write them down and also give her a copy when you walk in.
Understand.
Okay?
Yes.
Because if you do that, but keep your questions keep the number of questions reasonable. Don't ask more than, say, 6 or 8 questions. So you have to phrase your questions. But if you hand her that piece of paper, she'll answer every question on that piece of paper.
Okay. Yeah. Good. Yeah. I've been forwarding information via my chart to them too, and they've been responding to that. So I try to give them everything I have, and I may be.
Now, the second thing is that what you want to focus in on, because this is really why you're going to see her, is this issue as to, do you need or should you be on one hormone therapy drug or 2 hormone therapy drugs? Do you need a second line, what's called a second line anti-androgen? Peter, could you write second line anti-androgen into the chat window for me, please? So, do you need a second line anti-androgen? Because this is the whole issue when you first came to us, that we felt you probably should be on a second line anti-androgen. That's what's recommended, not just Eligard or Lupron or whatever it was.
Firmagon.
So that's a very important question.
Right. Yeah, that seems to be the primary question. I agree. And I understand what you're saying. I've read plenty about that in those guidelines. They thoroughly explain that.
Good.
Um,
Okay. What's the
I
next
have
thing on your mind?
just a when I started the hormone treatment at that time, I did not have a bone density scan, and
Right.
I'm wondering I mean, it seems like I should go in and get one now.
Yep.
Is that what you think?
Yep. I do think. I mean, they should scan you. They should do a bone density scan before they put anybody on longer term hormone therapy. And it's never too late. You're not there. You are you're in the midst of this treatment, and you need to know. And then you also need to have a discussion with Dr. Sokolova as to whether you need a bone strengthener like denosumab or it's just come from my mind, the drug that I took, Zometa. More likely Exgiva or Prolia or one of those bone strengthening drugs.
Yeah. So does this hormonal treatment? I mean, is it aggressive in terms of affecting bone density, or does it depend on the person?
Well, it depends on the person. It also depends on your starting point. I mean, when I was diagnosed at age 56, and I found out that I was osteoporotic. I mean, I had no idea. So I had an issue even before I started. And we know that when you don't have testosterone in your body, your bones weaken.
Yeah.
So
Okay.
that's why it's important to know what your bone density is, and your doctor should have done a bone density test. He is not alone. A lot of the doctors don't, especially if they're not GU medical oncologists.
Yeah. Yeah, that seems like quite a shortcoming on his part, that I be put on this type of treatment, and I was not encouraged to have a bone density scan. They did want me to have the other type, the nuclear medicine type of scan to detect lesions in the bones, but I opted for the PSMA CT scan.
Okay, but
instead.
these are very different things, and I would say the bigger shortcoming was not to put you on 2 drugs than not to give you a bone density test.
Yes.
That's
Yeah.
a much bigger shortcoming than the bone density is definitely a shortcoming, but it's the lesser of 2 sins here. Anybody
Yeah.
else want to talk to Tom and suggest things he might want to talk to Dr. Sokolova about? A few of you have remember your first appointment with GU medical oncologist. Anything that you can, any tips for him? Okay, you've got a few things out of us. Okay, Thomas?
Yes. Very good. Thank you very much.
Pleasure. Okay. Tony Fig, did you say you wanted time or not? I can't remember. I'm not sure.
Yes, I had a question.
Go ahead.
This pertains to muscle atrophy in the penis and penis shrinkage. And I was wondering if there's been any discussion on whether it's beneficial for a person to use like a vacuum pump so that there is blood flow to the organ, or I'm not thinking of it from the point of view of for sexual intercourse, but just for the health of the organ, or you just not do anything.
I'm throwing this one off to Peter because this is a discussion that he has a lot more often in his group.
Yeah, the blood flow in there will keep it from atrophying. I mean, you might not forget about sexual function, but the length of it, the use of it will atrophy pretty quickly without some kind of stimulation. Mine's certainly atrophied.
Mm-hmm.
I mean,
Well, I was thinking of, shrinkage too. If you're going to a
right.
urinal and you're, trying to urinate and it gets more and more difficult.
That it does. You're entirely right. So a pump might help on that if you, yeah, because it does shrink and atrophy.
Okay.
I think about
Joel,
that. Yeah, I think about
you
that
have your
because.
hand up.
Go ahead.
Yes. According to Dr. Mulhall at the last PCRI conference last September, he says the pump may help, but he prefers using Cialis 5 mg's daily. He says the Cialis does better for you than the pump. And so that's his opinion, and he's a sex doctor.
Thank you,
Mulhall
Joel.
said that even for people who have no testosterone, Mulhall said that.
So I don't know about Mulhall said that, yes.
Even for people with no testosterone, because he said that, definitely said that to me when I was seeing him saw him Kettering, post prostatectomy, and he said, yes, take the Cialis, take the Trimix, all that other stuff which I did to rehabilitate myself and maintain arterial perfusion. But how do you do that with no testosterone? Where does the motivation to do anything come from?
Okay, but that's a different issue, Dr. Jack. I mean, I accept the issue, but you're focusing in on the desire, and what we're talking about is the physical aspect.
I understand, but in the past it's been anything to maintain arterial perfusion. When I had testosterone, and it was very easy to either have sex or masturbate or use a pump or whatever you have to do. It takes Cialis and have erections. But now it just, it actually will work on the receptors and may have a partial erection if you take Cialis, or I haven't even considered it. See, I wonder how it interacts with all the other medication, with the primary and secondary androgen deprivation therapy and all the other medications. I mean, does this stuff hold up? Anybody doing it? Anybody taking Cialis?
Yeah, I mean, we can ask the group, but yes, I mean, we've heard it prescribed whilst you're on whilst you're on hormone therapy, and I'm certainly aware of Trimix being used whilst you're on hormone therapy. We got two hands up, Jimmy, and then we'll go to Mark Valens. Jimmy.
Yeah, I took it early on. I took it while I was still on deprivation. But it's interesting what Tony's saying. He's saying he's not necessarily having the goal of having a erect penis. Is that he doesn't want it to disappear completely. He makes it challenging even to pee sometimes because it disappears. And if that is the goal, I think that I don't see why in the world you would not do both. I use the pump occasionally, and I've taken 5 milligrams Cialis a day for a long time now. And I find that it doesn't work any miracles, but it does keep it kind of like from disappearing, I mean, it's nothing like what it used to be, and it isn't for a lot of us. I had surgery, I had radiation, and it's not a lot of action, but it does tend to keep it on the outside rather than on the inside. And I've always liked it on the outside because I don't have to go find it when I pee, and I feel maybe like Tony does. I'm not looking to have a salami anymore, but certainly if it's available, peeing is an ordeal now. Sometimes I have to make sure the lights are on. I got to make sure I'm pointed it correctly, And if it's sleeping too soundly and I have to go find it, it's just one more thing I have to do, along with waiting for it to stop dribbling because my AUS is not as good as my external sphincter was. So I think that the pump is good once in a while. It's good for a masturbation tool, and it's I can't see where it would hurt to have a little bit of flow down there. I don't know if Mulhall says that the Cialis is better. If I was really interested in having function again, I'd be using both of them. But if I can get there, I would have an implant, and it was better than either one of them. But that's a whole nother situation too.
If all of my nerves were taken during surgery for the prostatectomy, does Cialis affect anything if you don't have any nerves there?
Good question. I don't know.
Very good
It
question.
keeps the blood flow going better, and that's really important to get better blood flow to the organ. And so I take Cialis, and actually my urologist did recommend both the Cialis and either a pump or another way to keep having erections.
It's an interesting question, though. If you don't have any nerve bundles, what is it stimulating exactly? Yeah, I don't know. It's an interesting question.
I had a nerve-sparing procedure that really, made a difference in terms of being able to maintain and get an erection. Didn't hold it like I used to, but it certainly worked.
Yeah.
Now,
Good. You had nerve sparing. I had nerve sparing. There's a difference.
Well, Scardino claimed he spared it.
But yeah, I didn't get spared.
Can't hear you.
Okay, well, I appreciate the discussion. I was a little embarrassed to bring it up, but I appreciate it.
Yeah.
Well, thank you for bringing it up, Tony. I mean, it is an embarrassing topic, and God bless you for raising it. Mark Valens, I did want to mention to you that there is a very good, for want of a better term, sex doc, like Mulhall at UCSF, Tom Liu, and he has a nurse. Yeah,
I've met with him.
And his nurse practitioner, I'm not a big fan of nurse practitioners, but she's really good too. She's very, very good. I mean, most of the people I know that have seen her have only had very good, I can't remember her name off the top of my head. Peter, do you remember Tom Liu's? No.
No.
But she's well liked. Did you want to say anything else, Mark? You had your hand up. Was there anything else you want to add?
No, I wanted to add that my understanding is that even without testosterone, the Cialis will increase the blood flow, and that's a good thing.
Okay, so let me just do a quick review. We've got Jimmy and John Kish, and I know Dr. Jack wants to say a few words at the end if we have time about the blood, about the drumming, although really this isn't the forum so much for that, Jack. It's really the men speaking freely as opposed to.
We don't have to bring it up. I only had one thought. That's all. And John Fish never came in. You asked me to tabulate. Did he come in? I didn't see him come in. John Tish. You said I should tell you when he comes in. John Tish.
No. John Kish is in, but I'll yes, hang in on at the end, and I'll talk to you about the drumming.
Okay.
We'll talk about the drumming. So I want to get your thought on that. So John Kish, hang in, and Jimmy G. I think yes, you're up, and we got plenty of time.
Okay, I don't need plenty of time. This is not something I would normally bring up, but I thought I'd say a little something, and then I'm a little bit more encouraged to say something because of the discussion we had earlier about these. There's such a lot of drugs to treat overactive bladder, and there's the anticholinergics are the oldest ones, and when I was having all the problems I had, I was trying to solve only being able to sleep perhaps 3 to 4 hours at a time. And I was taking oxybutynin and then trospium was prescribed. And I stopped taking it because I deemed it not to work. So interestingly, after some time goes by, this has gotten worse for various reasons. This was all before I had my AUS. So this is a while ago. And then, you know, after the AUS and the other things I've had, my sleep really got disturbed and to where I was getting only sometimes 45 minutes, an hour at a time. And I found that when I got an hour and a half, that was like a big deal. And of course, I looked up and was not surprised to find that sleep cycles are about 90 minutes to 110 minutes at a time. And if you're not sleeping that much, it doesn't matter how many 45 minutes at a time you piece together, you're going to get the kind of rest that, you know, emergency room doctors and soldiers sometimes get, you know, really, really bad interrupted short intervals of sleep. And it's so hard on you. And so I was, yeah, you know, I was working on it. I was taking different kind of drugs. I was taking over-the-counter sleep aids. I was taking the trazodone, and that was making me crazy. And I was really at my wit's end. And then, you know, I just stopped taking everything, and that worked a little bit better. And then I found an old bottle of trospium in my cupboard, and I thought, well, why not give this another try? And you know, it's an interesting thing. When I was trying to get my sleep back from up to 5 hours at a time instead of 3, it wasn't doing me any good for that. But when I started taking it to get 45 minutes to stretch into 2 hours, 2.5 hours, bingo. You know, I think it's a really interesting thing that a drug that you figure isn't working, then when your situation gets worse and you try it again, why, you know, it's like it turns into quite a wonderful drug indeed. I thought that's an interesting thing to happen to anybody. That's what happened to me. So now I'm taking that daily and 60 milligrams, and I'm sleeping for 2.5 hours at a time, sometimes even a little bit longer than that. And I still have the 90-minute interval, but I don't have the 45-minute intervals. I don't have the 1 hour only at a time. And it's made a world of difference for me. I never knew that sleep cycles were an hour and a half long. I thought that if you didn't get 3 or 4 or 5 or 6 or 7 hours at a time, then your sleep was going to be, you know, unreasonably, or not, you know, unreasonably, it was going to be impaired to a severe degree, even if you put together pieces. But it depends on the size of the pieces. And now that I'm getting larger pieces again, I'm much happier. And even though I can only sleep for 2 hours at a time, generally at the most, compared to what it was, it's good. And then the skill position is going back to sleep. So after I've had about 6 hours, I'd love to get 8, but it's very difficult for me to get that last piece unless I go to bed early, and I don't like going to bed early. And if I stop drinking coffee, it would be better too, but I don't want to stop drinking coffee. So, you know, I should probably go to bed at 10 o'clock at night and not drink any coffee, but I don't want to do that. So I'm not going to do that. But I found a peaceful enough compromise, and a quality of life issue for me is not going to bed at 10 o'clock and stop drinking coffee. I'm sorry to say. So my brother, who's a retired physician, told me exactly that. He said, go to bed early, stop drinking coffee. I said, thanks, bro. It's good to see you. So that's the thing. So I just thought I'd mention that, just especially with the drug, you know, working not for what I wished it for before, but now working very well with a lower bar. Does that make any sense?
So what is the drug that you're doing so well with?
Trospium. Trospium is a anticholinergic. It's similar to oxybutynin. Those are the older class of bladder relaxers. Now the stuff that you're talking about, the Gemtesa, those are called I think beta 3 agonists, and there are a bunch of those.
Right.
And then they've got the hormonal, you know, the what do you call it, antidiuretics. There's a couple of different classes, and there's Flomax and there's different things. But I might actually try combining a couple of things. You know, I tried to look up the difference between the Gemtesa and the trospium, and the only things that I found when I put in Google, what is the difference between these two drugs, is a whole bunch of articles and studies about combining them. So maybe I'll try combining them. I don't know.
Have you tried these? Have you tried Gemtesa or Myrbetriq?
I have not. I've only tried oxybutinin, and this trospium.
So I would really encourage you to try either the Merbigran or the Gemtesa, which is something Gembigron or something like that. I can't remember its name. They work differently, and I know a lot of guys who have, not a lot, but a number who have used them have found them so much better,
You said the
including
Gemtesa, and what's the other one? The Mybetriq, is it? What is it? Is that what you said?
Myrbetriq,
I've heard of it.
right? But I think that the Gemtesa, which General Joel has been using, is probably better than the Merbigran. It's a more recent drug.
Well, just knowing Mr. Blanchett is obviously military grade, so I should give it a try.
But I want to say one other thing, that is, you talk about these hour-and-a-half sleep cycles. Most of us who have done long-term hormone therapy, we wake up in the morning like a Mack truck hit us, like we just can't move our legs, we can't move our arms. I mean, it's like, what did we run into? And we think we got a good night's sleep. In fact, what happens is that those good old hot flashes occur right the way through the night, and they wake you up. But they wake you up to an extent that much of the time you don't realize it. Some of the time you do. Some of the time you'll wake up with a hot sweat and you say, oh my God, I'm getting a hot flash, and blah, 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 blah. But a lot of the time you don't even realize it. So your sleep cycles are being interrupted right the way through the night when you're on that hormone therapy. And when the sleep cycle is interrupted, it affects so many other things, as Dr. Jack, I'm sure, will attest. You know, you got a list as long as your arm if you don't get a decent night's sleep. So I wanted to make that that comment. And Jimmy, I'm delighted the trostium's working, but I'd be even more delighted if you got even better sleep.
Well, thank you. So would I. You know, my wife is out of town for a month. She's her mom's in a nursing home and she's cleaning out her old house, and she let me fly back early. So I'm adult supervision for about a month. She'll be up there. So I don't have her snoring like a fat man next to me. I don't have her, stealing the covers and such. So I can kind of honestly assess the situation.
This is being recorded. Remember that.
All right, Jimmy, I hope Nancy doesn't listen to these recordings, man. That's all I can say.
Don't blackmail me.
I was going there next, but now I can't.
Preempted that shit. Okay, I'm done.
Okay, before we go to John Kish, and by the way, I sent you a little note, Dr. Jack. Before we go to John Kish, anybody else want to talk to Jimmy about these issues around bladder and sleep and what have you? Okay.
Yeah, Jimmy, I'm pretty much in the same cycle as you. 2 hours pretty much is regular, and it's been that way for years for me. And I go right back to sleep. But I found recently, I was told by my surgeon to get off of caffeine. I've drank coffee sometimes, but usually it's just chai tea in the morning. So I just cold turkey stopped. It took about 7 days to get the caffeine withdrawal gone, but it makes a difference in my sleep. I notice. I feel much better. I feel much better waking up in the morning. I feel I've got a lot more energy throughout the day, and I thought I'd have to have tea, a cup of tea or something in the morning to get through the day, but I no longer feel that. I'm just my energy's pretty even now, so it made a difference for me.
Well, you sound like my brother, so that's good.
Well, I'm not lecturing you. I'm just telling you
I know you're not.
my experience has been this past month.
I know you're not lecturing me. I'm still resistant, but I may surrender. I may. If I thought I could get, the thing is, he criticizes me because he says, you won't even try it. And I go, yeah, it's my nature, man. I used to take all these recreational drugs and now I don't take anything. So caffeine's like the coffee's like the last thing I have left, and I protect it with my life. It's crazy.
Yeah, and
I give it up.
it's a social thing too. Yeah, for sure. I mean, it's a very effective social thing too to sit down with someone over coffee or tea and
Oh, why it's not social for me? I come in my office in the morning. I sit here by myself and I get a lot done and I have the coffee. It's a ritual, but it's a fable. I mean, you have better energy without it. You have better sleep without it. I know all that. I'm just, an overgrown adolescent sometimes. So
it does take a week to kick it though. I mean, it's a tough week.
That's an eternity. I'll have to think about it.
Yeah, I know.
Thank you.
Okay, John Kish, you are up. Tell us what's going on.
Okay. Yeah, NIH said they would pay for me to go down there, but they want to redo the two scans that use radiation. And I called University of Penn and I scheduled for the 10th, but then I recalled them a day later and I said, can I go by myself? And they said yes. And then I recalled to make sure, and they said you got to bring somebody with you. And then kind of didn't realize it was like the New Year's Eve holiday coming up and maybe people were filling in, but I called like all these Penn numbers, the ones you gave me, and I had other ones, and even the College of Penn, and left messages with everybody, but they didn't call me back. But then I finally got somebody, and the social worker said I'm too far away. They won't help me get there. And then let's see, there's some kind of plane, a volunteer from where I live in Hazleton that would take me down there, but then I'd have to pay for the taxi. But I don't have anybody to go with me if I need somebody. So then I called Fox Chase. They said I wouldn't need anybody. So it's like really complicated. And I called the Patient Access Network. You have to fill out paperwork, but they said that they cover Nubequa and Lupron, but my Lupron's already covered. And then I'm getting a PSMA PET scan locally on the 11th. And then Alan Babcock was saying to ask you if I should cancel the appointment. And I don't know if I could get there because I don't know if I'm getting paid what date this month I'm getting paid with disability, because if I have to pay for the taxi, my friend said if he goes with me, he doesn't really want to go, but I would have to pay that myself. And my bank account's either has $6 or it's negative, and if I get paid on the 3rd, I have some money, but if not, I don't have any money. So yeah, and that's all complicated. And then I don't care where I go. I just not a fan of Lupron, but my local doctor I see February 5th, and he's going to go over the PSMA PET scan, And my sister said she would go with me, but she needs 2 months notice. She lives in Laurel, Maryland. So can I wait? Should I just take Lupron with the local doctor and then in 2 months go down with my sister to the University of Penn? I don't know.
Okay. So the first thing I can tell you is that UPenn doesn't need for you to be accompanied, provided you can get there. Because I spoke to you. Okay? So I don't know what you're hearing. I can't explain what you're hearing, but...
Well, that's what the one lady told me, but I think they probably had fill-ins because of the fill-ins for the holiday. Yeah.
Okay, John, just let us speak now, because we got the picture, and let us try and give you some advice and try and navigate you, okay? You can go to UPenn without being accompanied, but you have to figure out how to get there and how to get back, okay?
Right.
That's number one. Number two, Patient Advocacy Network, which I think is different from Patient Access, but whoever it is, Alan gave you the message. Those people have a $500 credit card if you're less than 5 times the poverty level. So if you're making less than
Yeah.
5 times the poverty level, you can get a $500 credit card that you can use for transport. You can use that for Uber. You can use that for whatever transport you want to use it for. That's what it's there for. So that should take care of your transportation. Now, I can't tell you how to apply for it, but John has given you the number, and you want to call those people. Alan has given you the number, and you want to call those people. And a big shout out to Vic Pagliasotti, who heard us talking and sent me an email and said, check this out. I think it's Patient Advocacy Network. There's a couple of them and I get them confused. But I know that I sent the link to Alan and Alan gave you the link, and you need to ask them about that credit card because you are eligible, you can get it. Third thing, if you want to try and get on to monotherapy, a monotherapy second-line anti-androgen like apalutamide, abiraterone, darolutamide, or enzalutamide, you're much more likely to be able to convince the doctor we've sent you to at UPenn.
Okay.
Based on our experience. There's no point in just calling up Fox Chase because then you don't know which doctor they're going to assign you to. Now, Alan's doctor, Dr. Gainesman, may be willing to do it, but he is not as flexible, in my view. He's a very good doctor, but he's not as flexible as Dr. Narayan at UPenn. I don't know why you made an appointment with Dr. Narayan for January the 10th, because you and I, when we talked, said you're much better off having the PSMA scan before you see Dr. Narayan. So
Right.
if you know
Well,
you're having the
when I talked
PSMA,
with, okay,
when
yeah,
if
but you
know,
told me to make the call to set it up, so that's why I did.
that's right. But I also told you get the PSMA scan first. So why make an
Yeah.
appointment the day before? I mean, we can't take care of every little detail. You know that PSMA scan is going to be critical.
Right.
So don't make an appointment the
Okay.
day before you get it, because how are you going to review it with Dr. Narayan? Then you're going to be telling me, oh, I can't get back to Penn to review it and I need to see him. No, you got to use your noggin a little bit, man. We're doing everything we
Yeah.
can to help you out here.
Okay. Yeah, I realize it, but okay, sorry, but I still see it. Now, this might sound bizarre, but I still think my intellect. I'm off Lupron almost 14 months, and my brain isn't what it used to be. I know I'm like 2 years older since the Lupron, but it really causes severe,
Okay,
in
but
my opinion.
that's not what we're talking about. We're trying to get you a solution that doesn't include Lupron or Eligard or any one of those
Right.
similar drugs. That's what we're trying to do. And the way we've
Okay,
figured
that's
out,
fine.
the best way we've figured out to do it, and it's not a guarantee, is to go see Dr. Narayan.
Yeah. Okay.
And
All right.
once you've got the PSMA scan and the appointment with Dr. Narayan, we are happy to give Dr. Narayan a heads up. He knows us well. But you've got to do your part of this, which is to do this in order and to get your ass to UPenn so you can see Dr. Narayan. Has UPenn assigned a caseworker to you yet?
with Dr. Narayan, I talked to the caseworker, and okay, I don't have one yet. No, I talked to a caseworker with them, but I guess until I officially get down there, I don't think they help you. I mean, I don't think they do it by the phone
Okay,
until
so
you.
you tell them that you need help with this patient. If you have the information to get the $500 credit card, is that right?
Yeah, I do. And then
Okay, so if
Cancer
you have
Care will
that
give you 500. Yeah,
okay,
sorry.
so
Go ahead.
if you have that information, tell the caseworker you need help to apply for it so you can get to them. And if they won't give you help, you let us know and we will try and get that organized. UPenn knows that you need some assistance. Okay? Don't
Right.
get angry with them if you can help it. I understand it's easy to get upset, it's easy to get angry with them, but they will not work with you. We've told them they need to work with you
Okay,
because you
good.
need the help.
All right.
Okay?
Yeah.
But you've got to
Yes.
take care of some of these things. You've got to get that $500 credit card, number one. You've got to get the PSMA scan, number two. You've got to get the results of the PSMA scan sent to Dr. Narayan, and you've got to make an appointment with Dr. Narayan.
Yeah. All right. And I have four other things not related to this that I wanted to ask or bring up, but if you don't have time, yeah. Okay.
Okay,
You want me to save it for next one?
let's go. We've got 4 minutes. Let's go through them quickly.
Yeah. Does the radical prostatectomy cause an inguinal hernia? Because I think I had some of it, but then after I got it removed, like my penis is way back in, like it's almost like I don't have one.
Okay, well, we talked about that. We've talked
Yeah.
about that today. And yes, a radical prostatectomy can cause a hernia, but I don't know if it, and I think it can cause an inguinal hernia,
but
I'm not
it's not
ready up on that.
life-threatening, right? That's
Dr.
not the
Jack.
type that's is that life-threatening or no?
No, it's not
Okay.
life-threatening. And I think Dr. Jack stepped away. You might know. Does anybody know? Has anybody had a hernia as a result of an RP here? It's pretty common.
It's pretty common. I've never had it, but a lot of guys do.
So the answer is yes. If you feel you have a hernia, if you can feel something there, it could have been a result. But normally, you had your RP 4 years ago, did you not?
That was 11 years ago, but I think I was
11 years.
yeah.
I think
But
you
it's
would have
even
had. I think you would have had the issues with the inguinal hernia before now. Dr. Jack, inguinal hernias and radical prostatectomy. Anything to say on that?
They occur, not commonly, but they do occur. I had radical prostatectomy. I had no inguinal hernia. If you want to have a repair of the scar, especially, there's always a risk that you can have an inguinal hernia, because I thought about that when you have an open procedure like I had.
Yeah, because I'm pretty sure I have it. Yeah, well, yeah. Okay.
Easier to check out.
Yeah.
It's not ominous, and it's a simple procedure of putting mesh in there.
Yeah, because when I have to pee, I have to sit down, because if I stand up, it's going to be all over. Not to be crude, so. But can they repair that or no?
If you have an inguinal hernia, you can repair it. Yes.
So then maybe I'll be able to stand up and actually urinate standing up, or
the doctor
hopefully
talk to your primary care physician and ask them if this could be a cause for your penis retracting, or it may just be the issues that Tony Figg spoke about earlier on. Okay?
Yeah, that's fine. Yeah, okay. And I quit coffee, and it didn't help my sleep. And I have other pain besides the stuff that's caused with the Lupron. The more coffee I drink, the less pain I have. So is there proof for that? That it helps with
I
pain?
think I think everybody's different, and if you're managing your coffee and you don't feel it's affecting your sleep, then keep doing what you're
Yeah,
doing.
I have a high tolerance to coffee. They say you can't get a tolerance to coffee, but I think I do. I mean,
No,
I'm not saying that that's a good thing.
no,
but I just,
that's not true. There's a certain gene, because I've read articles on this, that some people have, or a mutation in that gene which allows them to tolerate coffee. I'm pretty certain I have it, because I can
okay,
drink coffee
yeah,
right before I go to sleep and it doesn't make any
yeah,
difference for me. Some people
same
have a
with me.
very,
And
very high caffeine tolerance. Tell us your last
yeah,
thing, because otherwise everybody's going to go and it'll just be you, me,
okay,
and Dr. Jack, and I don't want
yeah,
everybody to leave. Okay, go on.
that oxybutynin helps with my daytime incontinence, but not at night. But it causes constipation, and then until I take my number 2, I leak just as much. So it's not a miracle on the oxybutynin. I have to take a lot of Fibercon and whatever Dulcolax or whatever. It kind of causes constipation for me. It decreases the urination, but it causes constipation. So that's the way it is with prescription. You know what I mean?
Okay.
Okay, that was it. Yeah, that's it. Sorry.
Jimmy, any experience with oxybutynin causing you constipation or not?
Yes,
You're
definitely.
muted.
It did. Yeah, it did. And the trospium did too, but not anymore because my diet has overwhelmed it.
Okay, good point.
I take a lot of vegetables and vegetable juices and stuff, and I don't allow myself to be dehydrated, and I don't eat a lot of low fiber foods, and of course exercise. They all,
Okay.
they're all effective.
They all help to work. Okay, guys. Well, look, it's 8:02. We've gotten through everybody. It was a small group. It was a real pleasure. Happy New Year to all of you. Thanks to everybody who has donated. I'm really grateful. And for those listening on the recording, if you haven't and you value what we do, please consider a donation, but it won't be deductible any longer in 2023. But we thank you. People have been very generous this year, and we are most grateful. Dr. Jack, don't hang up, please. All right.